welcome to this presentation on C-CARA, the Comprehensive Addiction Recovery Act. And so I'm excited to do this presentation. So welcome everybody. So we'll have still have some people that are jumping on. So we're going to get started. So my name is Pete Nielsen. I am the CEO for CCAPP. CCAPP is a California Consortium of Addiction Programs and Professionals. And so we do, basically we're the one-stop shop for the addiction field. So we have education, membership, recovery resources, and credentialing all underneath our roof. So we're able to help programs and professionals. One of the key things that we do is we advocate for programs and professionals throughout the state of California to increase treatment and recovery and prevention services and support. So I'm excited to be doing this presentation this morning. And so we only have an hour, so it's going to move relatively quickly. So thank you all for joining us, and look forward to doing this presentation with you. So CCAPP had realized a few years ago that it just seemed that our industry was being more reactive than proactive, and that we needed to do something to be able to change our industry in a meaningful way, that we needed to see what the deficiencies or the difficulties that we were having and make the corrections, and not wait for others outside of the industry to make those corrections. And so we were looking at, okay, what are ways that we think that the system doesn't work as well as it should? What are some holes? What are some gaps? Well, why don't things work the way that we want them to? And how can we improve our industry? How can we make a difference? I mean, CCAPP vision is to eliminate the devastating effects of addiction and make the world a better place. That is really what drives us and what's driving, our interaction with the legislature. And the other thing too is that we realized that this had to be bigger than legislation. It had to be bigger than regulation. It really needed to be a movement. So when we look at C-CARA, look at it as a movement. That this, is going to be a series of bills. It's going to be some regulation. It's also going to be the industry making some changes and doing some self-correction and doing some things from within as well. We see it as a three-pronged approach for improving the addiction treatment industry, to have smart regulation, smart legislation, and to have the industry be accountable and responsible and self-policing. And so with those, it's like a three-legged stool, that supports California. We believe that this is the path to make things better, to improve the industry, to make, and ultimately the goal is for this to have a deep and meaningful impact to the consumer. That we want to make sure that the individuals that are seeking services, that want to change their life, are getting the best services available, and that they are able to, we're giving them the support to be able to change their lives. So this is how I feel on most days, that going 190 miles an hour with my hair on fire, and because it's a wild ride, especially in these times with all the changes and what's happened federally, and it just seems like we're moving pretty quickly, and they're strapped onto a rocket. So just so everybody knows, that is not a picture of me. It's a representation, but not a picture. So that was a joke. So some of you that are laughing, that's okay. So really what we look at with C-CARA is that we looked at it as, we saw that the federal legislation was moving forward with CARA, and we liked the fact that there was so much support from the industry and from the public, and we said, we need to tap into some of that. C-CARA really doesn't resemble CARA federally. Just we share the name because people recognize the name, but it's really different in a lot of ways. CARA was more of a criminal justice bill. This is really a movement. So it's California's comprehensive blueprint for addiction treatment, prevention, and recovery services, reformulating resources, priorities, and vision to focus on addiction as a public health crisis. It's really important that we move from this criminal justice model to that it's a public health crisis, that this is not a moral issue, that this is a disease, and that the individuals suffering from the disease are not bad people. They're good people, that some of the symptom of their disease is bad behavior, but that doesn't make them bad people. That this is really a public health crisis that we need to take care of and to make a change. And it really affects everybody. And in order for us to improve the quality of lives for individuals, that we really need to treat this as a public health crisis. So the mission of C-CARA is this: to create the nation's first true on-demand addiction treatment system by guarantee access to treatment when the individual presents a need, and by eradicating waiting lists where Californians die while waiting for treatment. That is absolutely essential to this, that, we believe that it is a crime and that it is absolutely horrible that individuals that are waiting for treatment die in the process. If we truly believe that addiction is a disease, then why don't we treat it as such? If I go to the emergency room and I have a broken arm and I need to be treated, or if I have another medical ailment, they will prioritize and they will treat me, but I will get treatment. And with the disease of addiction, what happens is that I have a life-threatening disease and I need help right now, and I'm put on a waiting list and told to call back every day for 30 days and to see if I'm still willing. If I'm in pain, I'm willing. And if I have a broken arm and I go to the emergency room, I'm in pain and I'm going to the emergency room for a broken arm. Now, if the emergency room says, you know what, we're going to send you home, call us every day for 30 days and see if you're willing, and I die in the process, I'm going to tell you that there's going to be public outrage and that people are going to sue and people are going to be upset, that somebody with a ailment, when they went for help, they died in the process. Where's the public outrage for addiction? When somebody is turned away from treatment, no public outrage. There's no individual saying, somebody died from the disease. Many people say, oh, well, another addict died. And many people don't care. And, I think that is absolutely heartbreaking to see that human life is not treated as valuable, and that the individuals that seek help are not treated as human beings. Not addicts, human beings that, have pain, sorrow, suffering, and that there's a lack of empathy for those individuals, and they're treated as bad people. The disease of addiction, it affects individuals, and, what people see on the outside is typically behavior, but they don't look at it as a symptom of the disease. You can see an anvil on somebody's toe, but you can't see an anvil on somebody's soul. Meaning that if Larry, who's sitting next to me, if he drops an anvil on my toe, and you will hear me say some things that I probably wouldn't normally say. And if you would look at me, you'd see some behavior. You would see my arms filling, my facial expressions would be exaggerated, and you know, if you didn't see the anvil and you only saw all of that, you would think something else. You would think I'm angry, I'm upset. You would think all these things. So you wouldn't tie what's happening with me until you knew that there was an anvil. We can't see the anvil on somebody's soul. You know, we can see it on somebody's foot, but we can't see that pain, that torment, in their soul. So we chalk it up to bad behavior. So I say all that to say that we need to make changes in how people see individuals that suffer from the disease of addiction, and to see that they are people that need to be treated, and they need to be treated with dignity and respect. So moving forward, C-CARA's mission will be accomplished through legislative action on a set of legislative bills to address each of 4 areas identified as cornerstones of a comprehensive treatment on demand system for California. These we call pillars. So we have 4 pillars that we lump the different things that we want to see changed in California. It's really a upgrade of our treatment system. You know, it's sad to say, but we haven't had a thorough upgrade of our treatment system in a while. We've upgraded, you will upgrade your software for your computer more oftentimes than than upgrading the treatment system, and things are changing regularly in the system that we need to improve upon, and that the science is coming out. There are a lot of great things that we need to keep pace with, and the industry needs to stay up to date, and we need to do our best to do that within California. So we need to be responsive to that. So the first pillar is physical capacity. We really truly need to make this a treatment on demand system, which means that we need more treatment facilities. So how are we going to accomplish that? Well, there needs to be funding for construction, for new treatment facilities. There needs to be expansion for hospitals. That's not the only expansion, but there definitely needs to be that there needs to be more detoxification units accessible with hospitals. We also need to see, the purchase and maintenance of sober living or recovery residences. We need to see that we support the expansion and the creation of more housing for individuals that suffer from the disease of addiction. So we need to have inclusion of the addiction treatment and recovery residents in incentivizing developers to want to have recovery communities a part of their plan. Also, what we'd like to see is that for nonprofits, that a waiver of the per bed licensing fee. So in the state of California, there is a licensing fee. It used to be $100 and something, and now it's $300. 2014, it was $100 and something, and then now it's $300 something. What it's done is it restricted the amount of beds. So many treatment facilities that weren't at 100% occupancy, that they're losing money because they have to pay for that bed. And so instead of keeping that bed, they would limit the amount of beds that they have, and then so when they need those beds, they won't be able to utilize those because they don't want to pay for them. So if we create a system where it honors having those excess beds, so when there is a need, that those beds can be filled, and that we have that and we build out that capacity, that will work better for our treatment system and make sure that there is enough treatment available for individuals that need that. So physical capacity. expansion. So we need to make sure that the public officials and the municipalities understand that fair housing and ADA. We need to make sure that when you say, in a county meeting, when you say those people, that's discriminatory. When you try to say that you don't want people suffering from the disease of addiction in your neighborhood, that's discrimination. We need to make changes. We need to do education. We need to work with those municipalities to help them understand that addiction recovery, addiction treatment is an asset and not a liability. We also want to have a voluntary recovery residence certification, and we want that to be in harmony. And we want to work with the community and not against the community. We want these to be resources for individuals. And if there are bad actors, we need to get rid of those bad actors and work with the community to make sure that there's good actors in their community, people that are doing best practices and are not patient brokering or doing anything else that is detrimental to individuals that suffer from the disease of addiction. So we want to have a mandatory certification for all outpatient treatment centers. So the core of this is that in California, if you want to open an outpatient drug and alcohol facility, you do not have to get certified or licensed by the Department of Healthcare Services. So there are outpatient facilities that are not under any regulation that are currently operating in California. We believe that it's important for a outpatient facility, if they're going to do addiction treatment services, to be accountable. Also, it is common, we've seen that treatment facility or outpatient or intensive outpatient treatment facilities, what they'll do is they'll charge insurance company for the IOP or PHP, and then have a recovery residence, and then give the housing for free. Well, that's called insurance fraud. If you're not, now if the housing is paid for, or you have a dedicated scholarship, and that's shown that the money is not connected to them billing for insurance, because if the insurance company is not paying for the recovery residence, then the insurance, then where's that money coming from for that recovery residence? So that's something that we want to see to make sure that individuals have housing, and that it is a fair practice, and that there's oversight. The other thing is that we found is that they'll have this PHP, and they'll have this recovery residence, and in their advertising, they'll call it residential treatment. Well, that does not meet the level of care for residential treatment, and there are individuals that are marketing as residential treatment, which is fraud. So technical assistance for local governments. We want to make sure that they understand the importance of addiction treatment, they want to understand the importance of addiction recovery, and they understand that it's an asset to have those services in their community. And we want to reduce stigma. We want to have a statewide campaign to reduce stigma. We want the individuals that suffer from the disease of addiction not looked at addicts, not looked at people that are criminals, not looked at individuals that are liabilities, but looked at individuals that need help, that they suffer from the disease of addiction, and that they can recover, and that there is hope. And so we want to see that the public views addiction differently. That it's really about human redemption. It's about, individuals being able to change and have, the life beyond the wildest dreams, and for our society to be able to support that. So another pillar is workforce expansion. So when we talk about workforce expansion, we need to expand the amount of practitioners that are available within the treatment system. There are not enough practitioners throughout the continuum. There's not enough CSAM doctors. There's not enough therapists that work with this population. There's not enough drug and alcohol counselors. There's just not enough to feed the demand currently. We're not talking about expanding here. We're just talking about currently. So what we want to look at is we want to have student loan repayment for drug and alcohol counselors. So we want to have the option, if they work in a nonprofit, to get their student loan taken care of so they don't have that debt when they get out of school. We think that that is essential to improving the amount of practitioners for addiction treatment, to have that available, and not burden those individuals with student debt. Also, we believe that there's hardships that many individuals may make close to minimum wage, unfortunately, and they're certified counselors. And we want to help them in their progression and on their career path. And so having a mechanism for individuals that have hardship or have, situations that come up, to have a certification and testing fee waivers to be able to assist them to increase the workforce. Many times individuals that are suffering, or I would say counselors, and that are financially suffering, many times they may leave the profession because they need to feed their family, and there's no help for them if they have some financial hardship. So we want to create a mechanism to support our counselors. We also want to have no-cost tuition for college and BPE schools for licensed or certified counselors. So I mean, there's BOG waivers. I mean, there is systems in place, but we want to increase that, and we absolutely want to attract more people coming into the addiction profession, addiction treatment profession. So we want to increase the amount of opportunities. So if we have, funding to where if they want to get into this profession, that they can do it at low or no cost, that would help to increase our workforce. We want to have more people that are interested in becoming addiction professionals. That we want to have this be the career for people that want to make a difference and want to be change agents. And so we want to have more individuals coming into the profession. Many times you will see in schools, there's a big draw for nursing, there's a big draw for marriage family therapy, but there's not as big a draw for drug and alcohol treatment professionals. So we want to increase that, increase the demand for that. Increase in reimbursement. So typically in most treatment facilities, it's fee for service. And so a facility will get paid generally for, contact with clients. Typically it's groups or individual sessions, but a counselor will have so many more duties above and beyond, but the facility will not be able to reimburse, or will not get reimbursement for that, for all the duties that that counselor does for that facility. So we want to create a mechanism where the facilities can get more money for having those staff for all of those additional services that they provide, that they do not get reimbursement for, so that they would be able to have be able to pay counselors better, which would increase individuals coming into our profession because they're able to make a living by doing things that they love. We want to establish a career path. We want to establish a career path where you have an entry level and you go all the way up to a license. We believe that having a license is essential, and I'll talk about that a little bit later, but we want to have a career path that from the bottom to the top so individuals can stay within the addiction profession and be able to increase their knowledge, skill, and ability and be able to help people better and stay within our system of care. So the next pillar is workforce professionalism. So we believe that a license is essential for drug and alcohol counselors. One of the reasons we think we believe is because right now with the 1115 waiver, the organized delivery system, there are individuals called LPHAs, licensed health practitioners, and there's MFTs, LCSWs, those within the BBS, and those individuals are able to bill for diagnosing and for signing treatment plans, and so that those LPHAs are able to get reimbursed. If we had licensed drug and alcohol counselors, they would be able to also become an LPHA, and then the treatment facilities would be able to get reimbursed for a licensed addiction counselor signing off on treatment plans and diagnosing. This is important because if you're going to sign off on a treatment plan for somebody that is within a treatment facility, it's absolutely essential that whoever that professional is signing off on that treatment plan and then that's making the diagnosis absolutely understands the disease of addiction and they understand what they're signing off on. And if they don't have competency in addiction, then they shouldn't be signing off on treatment plans. And so we need to create that competency, and having licensed drug and alcohol counselors will help create that competency to improve the care for individuals suffering from the disease of addiction. And we truly believe that if we have more licensed practitioners that are licensed drug and alcohol counselors, we'd be able to increase that because they would understand this population. They would probably stay within the addiction treatment system and wouldn't leave. If you have a marriage family therapist or LCSW, there's a lot of other options that they can do for their careers. So, with a generalist, they may go somewhere else, and they may only be here for a time. We may only have them as an intern, but then as they get experience, they may leave our industry, and we think we need to retain our brain trust, and we need to groom more people to help out with this industry, and that we need to retain our workforce and not lose our workforce. So we definitely want to increase the amount of practitioners, and so if you have from beginning to end a career path, this will help increase the amount of practitioners we have. And I get calls all the time from treatment facilities that have the funding to hire a therapist, but they can't find one in their area, and many times it's rural areas that they can't find somebody, and they're able to pay them a living wage, but they cannot find one in their area that wants to work in addiction treatment. If we had licensed drug and alcohol counselors, then they would probably more likely there would be ready availability of a licensed practitioner that wants to work within this population available for those programs. So we want to make sure that there's no wrong door. We want to have a coordinated system of care. We want to make sure that there's access. We want to make sure that that there's progressive levels for individuals to start out, in an entry level and then work their way up and with adequate supervision, adequate, support, and professional development. We also want that to have peer support, but we want to make sure that they support the industry and are part of, but they don't take the place of drug and alcohol counselors or certified counselors. That there is a place for them within the continuum, and that it's important to have that contribution within that. And so we want to see that there's a uniform standard recognition for those peer professionals and peer support. We want to make sure that we have a place for them inside the system of care. And we want to make sure that interventionists, recovery coaches, recovery companions, anybody within that spectrum, that there is accountability for them. That if they're getting third-party reimbursement, that they need to be certified within that. And at this point, there's no consumer protection with interventionists, with recovery coaches, with recovery companions. So we believe it's an added component to add to the ancillary services inside the addiction treatment and recovery system. So the third pillar is payment reform. We want to make sure that we get rid of the pay-to-patient. Pay-to-patient is that an out-of-network treatment facility that accepts a certain insurance will have the patient go through the treatment program, and instead of the insurance company sending the check to the treatment facility, they send it to the patient or the client. We think that that's a bad practice, because what happens when somebody gets $10,000, $12,000, $14,000, $15,000, $20,000 that should be given to the treatment facility for treatment and given to the client or patient? Many things could happen with that. One of them being that the client could spend that money and relapse, and it could be a trigger. The other thing is, even if they don't spend that money on drugs, and they spend that money on, let's say, a Harley, it sets up that client in the recovery being in debt. And if you're just seeing that it's needless and senseless for the money to be sent to the client when it should really go to the treatment facility, it doesn't make any sense whatsoever. We need to make sure that there are no kickbacks for clients. Clients are absolutely 100% not commodities. They're not to be brokered. They're not to be sold. They're not, that is body brokering, and it's absolutely wrong. Florida has you've seen probably lots of media around this in Florida. It's happening in California. We need to end that, and we've been Florida. It's happening in California. We need to end that, and we've been as an industry moving to make changes to make sure that our clients are not seen as commodities to be bought and sold, but as human beings that need help. We want to create an insurance task force to evaluate network adequacy. So with parity, there should be network adequacy for addiction treatment services. Many times there's not, so we wanted to create a task force to take a look at many of these items, barriers to access for addiction treatment in private insurance systems. We want to look at the level and knowledge of skills, including the use of ASAM placement criteria amongst the key decision makers who make treatment and coverage decisions. We want to make sure, it'd be nice if the insurance companies had a CSAM doctor. It would be nice if those care managers actually had competency in addiction treatment. Many times, somebody may not understand this particular population, and they may make decisions as far as if they're going to pay for that service, and they may not understand that there is particular and key essential treatment recommendations for the addiction population that they may not see in other populations. So there just needs to be education around that. So status of coding and rate systems for addiction treatment, including reimbursement rate effects on access to care. We want to have the status of parity implementation, including a minimum progress on prohibiting fail first policies and mandatory step-down policies, and policies for addressing multiple relapse patients. Those under parity, there shouldn't be no fail first policies. There shouldn't be mandatory step downs. So we want to look over and make sure that parity is being followed. So kickbacks, I want to talk about this. I talked about this before. That is inducement. It's, there's stark laws against Medicare, Medicaid kickbacks, meaning individuals getting paid for referrals for patients. Now, in California, the problem is that patients or clients, may not be under that particular law because that we're seen as non-medical in a lot of our functions under DHCS, so they may not apply, and there's loopholes currently in our system, and I'll get into that a little bit later. That we still have issues around business relationships that are financial kickbacks with interventionists, with urine collection, and so the same thing goes for fees. But some of the labs like Millennium had providing free point of care cups. That's also seen as inducement. And here's, I'm going to go through a couple of these. These are different companies that there have been a prosecution for in the past few years for similar issues around kickbacks. So you see Millennium Health had one in 2015, and they, you also had other companies that followed along with this. The other thing is that we've seen is recovery residences, that there has been supposedly investment opportunities. One of the companies was Sky Toxicology, that said, well, hey, we got an investment opportunity for you. And this is really a sham. It was to camouflage a referral arrangement. There's efforts to make physicians / programs into investors as a proxy to offer returns for referrals. So it's really just kickbacks. And we've seen this in treatment. We've seen them in, we've seen this more with recovery residences, and that people have fell into these investment scams, and a lot. Some of them were good-meaning people that didn't understand what this really meant, that they were actually getting kickbacks. And so I talked again about Sky Toxicology, Sky Labs. That was one of the cases that was in California with another treatment facility, that they paid for urine tests, and a lot of money was paid for getting those urine screens or urine tests. Um, so let's talk about legislation. So, and currently, I'll give you the rundown on what we're doing on our legislative agenda, kind of what that looks like. So, um, there was a bill that we had this year, which is AB 285, Melendez, which was certifying recovery homes. It was voluntary, and it really gave a minimum standard for recovery residences. The importance of this is recovery residences are not the same as licensed treatment. Unfortunately, many people in the community can't and do not understand the difference between licensed treatment and recovery residences or sober living. They look at them as the same. There's no definition in statute talking about what sober living and recovery residences. 285 would have made a actual definition of what recovery residences are. The other thing is that recovery residences fall under protections for fair housing and ADA because they're not licensed treatment. So there's certain protections as far as you can't discriminate against them in your community, and that this would keep those rights intact, but also, give some quality and make sure that that individuals would get safe and affordable housing while they're recovering, and why they need a place to live that's supportive with other people that are in recovery. And this would have been a great opportunity. Unfortunately, it died in appropriations, but it's something that we feel passionate around. We've seen this happen in many other states. Massachusetts, and one of them is one state that we believe is a successful model for doing something like this. And it's also part of a national conversation that we're hearing as far as there needs to be some quality and standards around recovery residences. And so we firmly believe that this is the next step for our industry, is to support the recovery community and have quality sober living homes or recovery residences. McCarty had AB 1512, which would tax manufacturer at a wholesaler at a rate of a penny a pill, or penny a milligram, excuse me, for the active opioid ingredient. What this would do is it would put money towards an opioid prevention and rehabilitation fund. Unfortunately, it didn't. It died. We're hoping that this bill comes back. We like the fact that there's money that would be going towards treatment. We think that's absolutely important, that we need more money that would go towards treatment. Currently, we have Bradford 636, SB 636. This bill is really important because what it does is it gives statute to deal with patient brokering and also marketing. So not always is it physical contact. It's referral services with call centers and other marketing practices that are, one, unfair business practices, but are also body brokering. So this would create statute that would be a start to putting the end to patient brokering. I mean, it's not only this law that would make a difference. We also need to have accountability within the industry, and that all treatment practitioners, all recovery residences, and all treatment facilities say that and absolutely stand against patient brokering, and that they're willing to be very vocal about that it's wrong and that it shouldn't happen, and that it's not good treatment to broker or sell clients to have a financial gain. And until we make those changes, it's not only just the law. It needs that we need to help to produce a healthy atmosphere amongst addiction treatment programs this that we need to treat all of our clients with dignity and respect. So currently, SB 636 is moving forward. Most likely, it's going to be on an urgency status, and it could pass this year, we hope. So it's moving forward, and we're excited about this, and it's something that we think is a step towards in the right direction for making these important changes. I'm not going to go over all of this, but the importance is that it puts guidelines, and it puts things in place to prevent or to deter patient brokering. So we had about 6 NIMBY bills this year. NIMBY is not in my backyard, and you can see the different ones. We believe that that many of these bills, you know, the fact that they would infringe upon or discriminate against people in recovery, that's what makes them bad bills, and that limits, you know, the expansion of treatment, the expansion of recovery. It limits, you know, and you know, we'd be in favor of those bills if they would consult treatment and the industry to see how can we work together to take care of these issues and really get rid of the bad actors and get more good actors and you know, not be anti-treatment or anti-recovery. 700, which we believe in the concept of 700, which is, you know, the workforce and having a career ladder. Absolutely think that it's essential. Our philosophy was that we believe that it's a good idea, but there just needs to make sure that people are not left behind in the industry, and that it grows the industry and improves the industry, and make sure that individuals are not penalized or pushed out of the profession that they love, and to make sure that that they're able to have a living wage while becoming a counselor. So, you know, in concept, it's good, and we're hoping that the organization that sponsored it will work with us to improve it, because I think that there's a lot of hope in this particular bill, but as it presently was worded, we couldn't support it. We felt in many ways that it would hurt the industry and wouldn't support the expansion of addiction treatment, and wouldn't support the current workforce. And it doesn't see it doesn't it really has flaws as far as with the organized delivery system, and it doesn't it really doesn't support what's going on in the state of California. So I think it's something that I'm hoping that we'll be able to work on and improve, and you know, for everybody in California. So for individuals that you know, that are part of this webinar, that are listening, and the question to yourself is, you know, this all sounds great, but what does that mean to me, or how can I get involved? Well, here's some ways that you can get involved. We have the website, CCARA.info. Please check out the website, and it will break down everything that I talked about. We'll talk about more. We have more coming with it. We have a financial piece that we're going to talk about of how do we pay for the addiction treatment system. All those things were great in all those pillars, but we need money and funding for that. So we're coming soon. We're going to be talking about, and we're looking at, maybe in the future we might do an initiative. There's really a lot of things that we can do to be able to create a better treatment system. So stay tuned. We need people to help us. We need people to really be our advocates at the local level, or and to interact with people and tell people that this is important, that we need to make changes to the addiction treatment industry, and we need to upgrade it. Also, attend one of our conferences. We have the Legislative and Leadership Conference that's coming up in March. We don't have a specific date, but it's in Sacramento. We go to the Capitol, and you're able to interact with legislators and really get involved in the process for making a change for everybody. I mean, we are in the change business, and so we need to be the leaders of change, all of us, and make it better. We need to make the world a better place. And we know that people that suffer from the disease of addiction, that recover or are recovering from the disease of addiction, they make better parents, they make better community members, they make better family members, and they it really improves the quality of our communities and California as a whole. So we truly believe that to improve upon many of the problems that we have in society, we need to eradicate the disease of addiction and help people that suffer from the disease of addiction. So you can schedule visits with your legislators. If you're a treatment owner, schedule with your local legislator to come and tour your treatment facility. Let us know that it's happening. We're happy to support you. Write letters about different legislation. We can support you in that. We have go to C-CARA.info, and there's a lot of information on a part of that, to be a part of that. And then be an active member. Be the light of the world. Be that change agent. And we're happy to support you, AATA, as well as CCAPP. We're both happy to support you and help you with that. And then attend political action committee events. On the C-CARA website, there's a tab to find out about political action committee and what does that mean and how can you help. And also either contact Sherry or myself, and Larry's going to put up, oh, he already did. Thanks, Larry. You're quick. Our email addresses. Also, what I want to talk about is how you can also make a change is being part of AATA and CCAPP. We offer dual membership, and it's a great opportunity for you to be involved in both organizations. And the great thing is we have a 50% discount if you join both organizations. So we have joined together to be able to improve and you can join as a individual practitioner, you can join as a recovery residence, or you can join as a treatment facility. So there's multiple ways. There's a link here on the slide, and Larry will also put that on so that you can click that link and go for the dual membership if you want. There's also a number you can call. And here's the benefits for each organization. For AATA, they are really the compliance experts. They're phenomenal at helping you navigate this sticky world that we live in and dealing with all the different regulations and rules and things that are in California and the industry as a whole. CCAPP, we are the leaders in advocacy for the addiction treatment industry, and being involved. And we have lots of other benefits. There's a whole list on our website of all kinds of different benefits that individuals can utilize. One of the things that is important is that there is an important tool for people to have is the Patient Financial Responsibility Toolkit. It has model policies, sliding fee assistant charts. It has talking points for staff, prompt pay versus cash pay discounts. These are all the things within the financial responsibility toolkit. I'd recommend, if you want more information, email us or go to the link that's on the slide. It's a great resource for you to have in your arsenal. So at this time, I want to open up we have a few minutes for questions, and so I want to be able to answer some questions. I know it was quick webinar, but thank you for hanging in there with me, and it's great to see so many people that are interested in the subject. So I'm going to open up for questions. And do we have any questions? Can a treatment center write a check and the treatment center's name for clients stay at a sober living? Okay, so it depends. So what's the funding source of that client? What's the relationship with the recovery home? I mean, I don't know what it is. I mean, generally it's something that could be suspect, but without more information, generally, is there a scholarship fund that has nothing to do with the funding source, such as insurance money, and is it appropriate? So generally, no. If the treatment facility is getting paid as a for intensive outpatient or for PHP, then unless there's a separate fund that is strictly for housing that has nothing to do with that individual's insurance, that would be the only way, but generally no.
I saw a question earlier about LPCCs being able to get reimbursement.
Yes, I believe they're part of the LPHAs. So yeah, under the Medi-Cal system, the organized delivery system, I believe they are LPHAs. Nobody should be paying for clients. So the question from Josh was, nonprofit organizations paying for clients insurance. Oh, absolutely not. That is illegal. There's cases where big treatment facilities have been indicted for paying for, especially clients that come from out of state. They were paying for policies, for ACA policies. Yeah, many of the bills are currently sponsored, so it is a plan for the future, and we're looking at more bills underneath the umbrella. But so far, we've had McCarty, we've had Melendez, and then we've also currently have Bradford, our legislators that have latched onto these issues, and we see a lot of legislators that are passionate about addiction treatment and recovery, especially since all of the focus is on the opioid epidemic. There's become a lot more interest. All right, so the last question, Kim G. Is there any funding available for nonprofit organizations that support for trauma prevention, substance use, and PTSD? There is. Larry will send you some information online, offline. Email Larry and he'll send you some information about these funding sources. So I just want to say thank you all. I appreciate your time and the opportunity to be able to present on this important topic. And, you know, if all of us get involved, we could make a real impact and difference on our society and make the world a better place. So, you know, please stay involved. Please, you know, reach out to AATA or CCAPP, and let's get everybody involved and let's make a difference. Thank you all, and have yourself a wonderful day.